Hi, my name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I'm the director of the cardiothoracic and stereotactic body radiation therapy services and director of clinical trials. For patients that have locally advanced non-small cell lung cancer, even though the predominant mode of failure for many of those patients is distant, increasingly with better systemic control with agents such as consolidation durvalumab and increasingly improved staging at the outset, we're finding that patients are living long enough to develop local regional recurrence alone. Now, if a patient develops local regional recurrence after definitive chemoradiotherapy for locally advanced non-small cell lung cancer, the potential for giving additional treatment is complex and requires a discussion of many different nuanced components, such as how that recurrence is diagnosed, the extent of disease recurrence, the duration between the initial treatment and the recurrence, the health status of the patient, whether that patient has symptoms from the recurrence, and the availability and relative risk of alternative options such as surgery and/or systemic therapy. Now, how that recurrence is diagnosed is pretty important. It is important to follow these patients closely. Often, or in the past, there was a therapeutic nihilism such that if the patients were going to recur, there was really no significant options to help them, so it wasn't important to follow them closely. However, the highest risk of recurrence was in the first 2 years. And so there is importance of close follow-up because salvage is possible. If a patient is suspected of developing recurrence, it's important to use the entire spectrum of tools at your disposal because it can often be very difficult to distinguish recurrence from post-radiation treatment changes. Now, PET-CT is one way to go about doing that, and that's probably the most common approach. If a patient has increasing density in the lung or increasing size or number of lymph nodes, a PET-CT can be an invaluable way to look from top to bottom, get a sense of how likely it is that that's true recurrence versus inflammatory changes, and also look for systemic disease. However, PET-CT is not infallible. PET-CT is prone to false positives in the settings of infection or inflammation. We're now seeing situations where patients who have had a recent COVID vaccine are developing inflammatory adenopathy in the axilla, which can look like regional or distant disease. So biopsy of those nodes or the primary itself is important whenever possible. The extent of disease recurrence is probably one of the predominant things that drives the overall decision-making of re-irradiation. If it's just the primary alone, and particularly if that recurrence is discrete, and if that recurrence is not highly invasive in the mediastinum, there is data to suggest that you can give salvage radiation with something like SBRT, or hypofractionated radiation, which is a more potent way to deliver dosing, and would certainly make sense when in fact the first course of therapy failed. So just repeating the second course all over again seems unlikely to work. If it's only in the nodes, well, then that's a second issue. For some of those patients, particularly if those nodes are outside of the primary radiation treatment portal, one could almost treat that patient as a TX, N2, or N3 patient, where you're salvaging them with definitive intent again, sometimes with chemotherapy as well, or maybe just radiation alone. Probably the most difficult situation is if it flat out fails right there in field in the primary and lymph nodes. And those are the ones that are the most difficult and frankly, most unlikely to be successfully salvaged. The other thing that matters is the duration between the initial treatment and the recurrence. A very short interval between the initial treatment and recurrence implies that the disease is just frankly refractory to treatment. So more of the same treatment is unlikely to provide substantial benefit. And studies have shown that while these cutoffs are not perfect, that a recurrence within the first 8 months after initial treatment suggests that that's a disease which is not likely to do well with salvage re-irradiation. Now, longer intervals, though, suggest that we maybe just didn't quite get those last few clonogens. And another course, particularly if that recurrence is smaller and more manageable, still has the opportunity to sterilize the disease. Because the biggest competing risk is distant failure, though, there is also reason to sometimes consider initiating systemic therapy first. Make them pass a litmus test for further disease progression before then offering local therapy, because the potential for re-irradiation and additional local therapy increases the risk of toxicity substantially. And so particularly if there's some question on the PET-CT or other imaging about whether that patient may be developing additional systemic disease, it may make sense to start with systemic therapy. I also mentioned the health status of the patient. That is really critical as well. Some patients come to us getting definitive chemoradiotherapy or radiation alone because they have significant medical comorbidities. They are at high risk for things like surgery. And unfortunately, they don't tend to get healthier after a course of chemoradiotherapy. So sometimes the disease recurrence radiographically may look like it's well suited to re-irradiation, but the patient just isn't in the position to take it, in which case sometimes things like systemic therapy alone may be more appropriate. The symptoms of the recurrence also drive this as well. If a patient has a symptomatic recurrence, regardless of whether the intention of treatment is cure, sterilization, or not, sometimes re-irradiation is appropriate, although to lower doses if the goal is perhaps just palliation of symptoms such as dysphagia or bleeding. And then of course, the availability and relative risk of alternative options really plays into this as well. So for example, if the patient came and they were otherwise reasonably a good operative candidate, but had extensive nodal disease at the outset, but then they only recur in the primary, that's a patient that might be well suited with a lobectomy. If a patient has a more significant recurrence, and then it turns out that they actually have a driver mutation or they're PD-L1 high, it may be that the risk-benefit ratio favors systemic therapy alone with a TKI or immunotherapy. So overall, the primary things that we worry about if we are going to embark on a course of re-irradiation are generally the esophagus, the bronchial tree, the vessels, the heart, and the spinal cord. Now, there's no hard and fast rules in terms of what's a safe dose to limit these organs. The experiences that we have are mostly retrospective. They're driven by institutional series. Generally speaking, the concern for the esophagus, bronchus, and vessels is going to be a late fistula. Trying to keep the cumulative dose less than 90 to 100 gray reduces that risk, but it doesn't guarantee that you're going to be able to deliver safe treatment. However, most studies would suggest that if you can keep that dose less than 90, 94, 100 gray, the risk of a late fistula becomes less than about 10 to 15%. From a cardiac standpoint, we're getting an increasing understanding that there probably really is no truly safe dose to the heart. So just doing whatever you can to minimize extra dose back to the heart is important. We're still now in the early phases of understanding substructures and which ones we might want to consider limiting more or less. I think that while this is not a tested approach, it's certainly a reasonable thing to consider to understand their overall cardiac function, and perhaps if they have a cardiomyopathy, trying to spare the areas of the heart based on nuclear scans where you know that they have viable myocardium. And the spinal cord, of course, is something that keeps radiation oncologists awake at night all the time. This is something where if you give re-irradiation to the spinal cord and you exceed dose tolerance, the outcome is paralysis. So there really is no situation where you would ever want to consider exceeding those dose tolerances. Trying to keep that less than 50 to 55 gray cumulative dose for the second course of therapy is important. Now, this is something that has been discussed quite a bit recently in the literature because, again, we are seeing more patients living longer. For further information on the nuances of this, you might want to consider reviewing a manuscript in Seminars in Radiation Oncology titled Challenges in Re-irradiation of the Thorax, Managing Patients with Locally Recurrent Non-Small Cell Lung Cancer. Another thing to consider in the armamentarium of tools that you may have to deliver re-irradiation is whether you might want to use protons or photons. Now, photons are the traditional approach, and this is the one we have the most experience with. Oftentimes, most centers would deliver that with a modern form of radiation, such as IMRT. However, increasingly, we have access to proton radiotherapy units. And one potential benefit of protons is that it reduces the intermediate or low-dose scatter radiation that may go back into an area that was previously irradiated. However, it is not magic. Many times patients are referred to my center specifically for re-irradiation with protons, and it may turn out that protons are not the best approach because at the level of the tumor, where you are delivering the radiation treatment to the high dose, to the prescription doses, there is very little difference in the dose delivered with protons versus photons. And sometimes that's where the highest risk of injury occurs, right in that zone where the tumor is recurring. So if you have any questions in a patient about whether they may benefit from protons versus photons, I strongly encourage you reaching out to your closest center, your closest regional center, Many of those centers are usually very happy to take a look at the prior plan and discuss whether or not it makes sense to send the patient for a referral.